Hello everyone, well that's louder than I thought. My name is Tanya McCurley, I'm the Executive Director of Sector Connect, and this is Pritika, she's our Senior Project Officer on this project. Sector Connect are really proud to be presenting this for the first time today. This is all about the Integrated Mental Health Service Project, which has been funded by SWSPHN. And before we get started, I'd just like to acknowledge the traditional landowners and pay my respects to elders past and present. So just quickly before I hand it over to Pritika, Sector Connect is your local peak body. We represent this region, particularly around strategic leadership. We do a lot of encouraging collaboration and advocacy, and you also might know us for running a lot of networks and interagencies. We also do projects and planning from time to time, such as this one. We have over 2,500 service users, and we represent over 400 organisations in the district. So if you'd like to know more about Sector Connect, we do have a website, www.sectorconnect.org.au, and you can find some more information about us on there and this project. So I'm going to hand it over to Pritika, who's going to tell you all about it. Thank you.
Thank you. Hopefully I'll remember to click and hold this and little things I have to do. Great, so we'll go right into it. So the Integrated Mental Health Service Project is really rooted in 2 stages of consultation conducted by Sector Connect. The first, which was in partnership with community-owned primary health enterprises, and both which were funded by Partners in Recovery. The first stage resulted in 19 options for different models of mental health service delivery. The 19th option, which was the development of an integrated psychosocial service that was centred around a general practice. Stage 1 led to Stage 2, whereby a number of these options were developed into 4 overarching projects. The 4th, which was the development of an integrated mental health service model. So these 2 stages have essentially led to the current project, which I guess you could call Stage 3. And that's what I'll be presenting today. So the Integrated Mental Health Service Project involves co-design of an integrated service delivery model and fits within the Primary Health Network's commissioning process. So Sector Connect was conducting these consultations and co-design on behalf of the PHN. Fundamentally, the broader issue that was attempting to be addressed was that the life expectancy of people living with mental illness can be up to 20 years less than the average person. And this results from often poor physical health outcomes and high rates of chronic disease. This is further exacerbated by a system that is often fragmented and difficult to navigate, so physical... Oh, good? So physical health issues are often missed or not treated within the general mental health care of a person. There's also evidence of social determinants to health. On a more local context, surveys of residents in southwestern Sydney found a greater percentage of people living in the region experiencing high to very high psychological distress compared to the New South Wales average. Respondents expressed that the system can often feel fragmented and difficult to navigate, that there was poor communication between providers, they perceived their care as not person-centred enough, and that physical and mental health were... That's not me. Physical and mental health care are approached separately. Further consultation with general practitioners suggested that GPs are requiring more support in treating people living with severe and persistent mental illness. And this continually came up during my consultation with general practitioners. The PHN also recently conducted a co-design on severe mental illness where some solutions to such issues were discussed. Some of the feedback included the importance of a collaborative approach to care, the need for clearer care pathways for clients, continuity of care, opportunities for shared learning between providers, person-centred and wraparound care, which is what was just discussed in the last talk, streamlined referral pathways so that those care pathways are clear for clients, improved waiting times, and acknowledgement of the interconnectedness between physical and mental health. So the following project focused on the co-design of the new trial integrated
Just come and let me know. 2, testing, let's go. We don't have a stage today, so I'm sure that.
Trial integrated subspecialty clinic providing coordinated wraparound care for people living with severe and persistent mental illness.
Oh, it's still not going up.
Such models of integrated care and care I just hope it's not distracting for you guys. Such models of integrated care and care coordination has been supported by New South Wales Health, the Mental Health Commission, particularly in their Living Well report, the Australian Government's National Mental Health Reforms, and also endorsed by the World Health Organisation. There have been some attempts of integrated and coordinated service delivery in both New South Wales and Australia and also overseas. Some local examples include LikeMind, which is an adult service for people living with mental health issues, which coordinates client care across both community and health services. Headspace, which we should all really be aware about, provides early intervention mental health services to young people aged 12 to 25 years through care coordination and appropriate referral. Then we have General Oran Park Family Health, which is another example of integrating and coordinating care for people within primary health. And overseas, there's the Sandwell Integrated Primary Care Mental Health and Wellbeing Service, which the name kind of suggests what that is. And the King's Fund in the UK, which reports significantly on the benefits and challenges of integrated models of care. Some of the factors that are common to such attempts at integrated and coordinated service delivery include information sharing systems where providers can share information about their client and the care of their client, shared protocols, joint funding commissions, co-located services so that these services are easier to access in the one kind of hub, multidisciplinary teams which can support client care, liaison services, care navigators, component of research and continuous evaluation and improvement of models, and general reduction of stigma, particularly within the primary health system. There are a number of benefits to integrating mental health services into primary health, and these include the reduction of stigma when seeking mental health care from a primary healthcare provider as opposed to having a standalone specialised service. The improved prevention and detection of mental health disorders within primary health services. Improved access to mental health services and treatment of comorbid physical health conditions, as mental health and physical health are addressed together as opposed to separately. The upskilling of primary health care workers in mental health skills promotes a more holistic approach for patient care, therefore also improving prevention and detection of mental health disorders. Might also prevent people from being admitted into hospitals and psychiatric institutions by providing that continued wraparound responsive care to the patient at a primary care level. And finally, it improves human resource capacity by sharing workload and expertise and resources. There are, of course, some systemic challenges, as you would expect, which may contribute to why there's few attempts at adopting such models, particularly in New South Wales. These include the financial and time investments required to train staff and coordinate services, and again this came up a lot during consultation. The reluctance of providers to participate in integration and coordination. The capacity of general practitioners to treat patients living with severe mental health conditions, again, which came up during consultation with general practitioners. And that healthcare is funded through both the Commonwealth and state governments, and it's often done separately with little coordination between the two. So the proposed model is really a new approach to addressing these issues at a micro level by bringing together the state and Commonwealth governments and the private and public sectors, and supporting general practitioners in treating patients presenting with severe mental illness. So now to the actual project. I was working with Sector Connect as Senior Project Officer for 3 months on this project. And for about a month and a half of that, I was running consultations. So the consultations involved engagement with key stakeholders in southwest Sydney, and this included 205 key stakeholders engaged across 32 mediums, which included one-on-one interviews, group consultations and surveys. Those included 130 service providers and practitioners, 29 GPs and 26 consumers and carers. The consultations led to a co-design workshop with 14 stakeholders from that group of 205 stakeholders. And the workshop really focused on 4 key areas. That was developing the service model, how the service would be coordinated, the governance structures and resourcing needs and where the resources might come from. So essentially this is what the service itself would look like. The service model is for a subspecialty clinic based around an existing general practice. Therefore, the general practice is, this is why the general practice in this picture is at the centre of the model. Of course, with the general practice will come GPs and nurses and all the other people that come with a general practice. Surrounding that and connected to that is your mental health services. And what was seen as a priority is affordable clinical services such as psychologists and psychiatrists, and a focus on stepped care. There was a variety of social supports that were suggested during consultation, focusing on issues that people living with severe and persistent mental illness would experience. This was particularly around alcohol and other drugs, family support, housing and homelessness, employment, financial counselling, and education. Then linked to that also would be other allied health services, a particular focus on physical health. And that was around priority on diet and exercise, preventing risk factors to physical health issues, and reducing the side effects caused by medications. And some of the suggestions were to co-locate dietitians, exercise physiologists, occupational therapists, and programs on, for example, smoking management, diabetes and nutrition. A pharmacy would also be important as part of this model to provide medication and education. Access to the clinic can be via self-referral or external referral from services outside of the actual clinic, and also through outreach, home visits and telemedicine. So I'll go back to one of the findings that I thought was a bit interesting from the consultation. And that was during the consultation, we found that GPs were preferring to refer patients that present with severe mental illness to particularly clinical services, so psychologists, psychiatrists. And so this particular module encourages the use of social support services and other allied health providers, therefore ensuring that wraparound and approach to patient care. In terms of service coordination, the consumer is really at the centre of their care, and throughout they're really at the centre of their engagement with the clinic. So upon entering the clinic, the client would be, of course, assessed by an intake nurse to determine what services are appropriate for their needs. Then they may be provided a care coordinator who can provide referral, support them in navigating all the different services that are linked to the clinic, and supporting them in developing care plans based on the needs of the client. Ideally, there would be a single referral system that's attached to a shared record system, which will allow streamlined referral and communication between providers. And for this to really work, all services that are participating in this model really need to commit to care coordination so that the client can receive that holistic and wraparound care, which is the purpose of doing this model in the first place. Finally, there will be opportunities for case conferencing for specific or complex cases, and opportunities for providers to learn from each other. So I think this model really acknowledges some of the things that came up during the co-design, the severe mental illness co-design I talked about earlier. The agreed governance model was for a consortium with an overarching government body, including representatives from various services and stakeholders, and a coordinating agency which would lead the overall coordination of the model. Services then would agree to participate in the model through memorandums of understanding. We did touch a little bit on resourcing during the co-design workshop, and it was based around the idea that the service would be a trial subspecialty clinic developed around an existing general practice as opposed to creating a whole new practice. So some of the resourcing needs would be, these are just some examples that were brought up during the co-design. Incentives for practitioners to participate in the model, and this was particularly, this came up a lot with the GPs saying that they needed financial incentives to participate in such a model. Resources for services to co-locate to the existing practice. The care coordination and integrated systems would need to be funded. So, for example, the care coordinator role would need to be funded. If there's new IT systems, and funding for practitioners and services generally, so they can provide affordable and accessible services to consumers. Some potential funding streams that were suggested included packages available through the National Disability Insurance Scheme, Medicare Benefits Scheme, the Southwest Sydney PHN's Commission Services, which you'd hear a lot about today, and any current and new local, state, federal, local, state and federal funding. So this clinic is essentially a public and private hybrid, closing the gap between the public and private health sector that is currently the context of the health system. It therefore achieves true integration of the current mental health system at a micro level. And the idea is for this to potentially, as a trial, lead to, if it's successful, could be replicated across other general practices. The public-private hybrid also increases access to a greater variety of funding packages and therefore income. And this is a bit of an example of how that might work. So providers were then surveyed and asked if they would want to be involved in such a model. 54% of GPs said they would be involved in the model, whereas 46% said they couldn't see themselves having the capacity to be involved. And of course there was a greater number of community services and other allied health services that said that they could be involved, so 90% said they could be involved. Some considerations for participation in the clinic for general practitioners included the time that they had available to during all the other consultations that they have to take, the time that they have available to treat people that present with severe and persistent mental illness, the resources and incentives for participation in care coordination in particular, and their level of expertise in treating people with living with severe and systemic illness. For consumers and carers, it came down to the cost of using the service, and of course a lot of them said they wanted the service to bulk bill. The location, and particular location in proximity to public transport, and once they enter the clinic, how easy is it to then access the services that are available. And for community and allied health providers, really centred around finding flexibility in how they, them as individual services, can provide whatever service they provide, and again, the location. Finally, these findings were reported to the PHN and some suggested recommendations. So the first recommendation is for to identify a general practice that's willing to deliver on this model. Then need to co-locate key services and fund co-location of services. Establish that consortium governance model and select a lead agency. Develop a robust financial plan that considers that it is public and private hybrid. Fund service coordination, including the care coordinator role and service participation in coordination. Incentivise service and practitioner participation. Develop those shared information pathways, including appropriate IT systems, and even identify what IT systems already exist that might be able to be adopted within this one. Create agreements. This is really important, to create agreements to ensure that integration and coordination are a condition for service participation. Undergo continuous evaluation and improvement, especially at the trial stage, and ensure streamlined pathways and coordination with community mental health to achieve true integration across all the different levels of healthcare. So we concluded that the model generally is well accepted by the stakeholders that we consulted, with some additional recommendations and considerations. And this has the potential to be replicated outside and within Southwest Sydney, but also outside of Southwest Sydney. So it's a really exciting project, especially if the trial is successful. Overall, the project paves the way for improvements in service delivery and coordination for the treatment of people living with mental illness, and more specifically, people living with severe mental illness.